Welcome. We're going to talk now about super drugs for super bugs. Imagine you're in the emergency department. 62-year-old male comes in. He's coming from the sniff. He's got fever, respiratory distress. We see a lot of these, right? So you have a few minutes while they're bringing him in, and you can look at his recent records. He was just in your hospital not long ago for a big surgery, AAA repair. He had all kinds of complications with wound infections and UTI, and the cultures grew all kinds of crazy stuff. He had Klebsiella, that was an ESBL producing organism. He had Acinetobacter baumannii, resistant to pretty much everything. Cephalosporins, imipenem, gentamicin, ciprofloxacin, our favorite zosyn, pip-tazobactam. So what are you going to do for this guy? All right, well, we'll talk about that because we're seeing more and more of these types of patients. Let's talk a little bit about just general concepts of antibiotic resistance. Now, there's a few ways that antibiotics can become that bacteria can become resistant to antibiotics. Sometimes they just destroy the antibiotic. One of those ways is with a beta-lactamase enzyme, where they have an enzyme in the bacteria that just destroys the antibiotic itself. Some of them can try to pump the antibiotic out of the bacterial cell really fast. They can have mutations that block where the antibiotic works in the cell. And then once they have that resistance, they can spread it around to other people, person to person, spreading on our hands even as healthcare providers. And some of these genes go together in plasmids where they tend to travel together. So when bacteria are resistant to an antibiotic, they're more likely to be resistant to multiple other antibiotics. So beta-lactamase, we're going to talk about these extended spectrum beta-lactamase producers, or ESBLs. You guys all remember from your pharmacology studies in school about beta-lactams, penicillins, cephalosporins, even carbapenems have them. And this beta-lactam ring is the constant part of all these types of antibiotics. And what a beta-lactamase does is it basically breaks part of that beta-lactamase ring and it makes it inactive. Same for cephalosporins, same for even imipenem. Even carbapenems have this beta-lactam ring, but not all of the beta-lactamases. There's a lot of beta-lactamases that can break down penicillin and amoxicillin, all those things. Far fewer can break down imipenem, but we are starting to see a lot more of these carbapenemase producing bacteria as well. So what are these extended spectrum beta-lactamases? So basically they can break down a broader range of broad spectrum antibiotics. They've been around for many years. They can pass around between bacteria. Mostly it's in E. coli and Klebsiella that are in the Enterobacteriaceae family, but there's a lot of other bacteria that can carry these things as well. Mostly we see them in Klebsiella and E. coli, but we can see them in a lot of these other types of bugs as well. Now, there are different subtypes of ESBLs that the infectious disease nerds love to go on and on about. For our purposes, doesn't really matter if we know specifically the one because mostly we don't, but it can make some of the lab detection a little bit difficult for some of these subtypes. The bottom line is that you know they're going to be resistant to most, if not all, cephalosporins, and many of them are also resistant to other things. If they're an ESBL, they're also very highly likely to be resistant to fluoroquinolones and other things like that. So the risk factor for these are kind of the common sense things that you would expect. People who've been in the hospital, people who've been in an ICU, they've had surgery, they got tubes coming in and out of them everywhere. They've had a lot of antibiotics. So that's mainly the risk factor. Where we will see them often in the emergency department is people coming in from long-term care facilities, nursing homes, et cetera. But we are also seeing them also in people who do not have any of the standard risk factors now. And we'll talk about that in a little bit of how often we're seeing them. So this was a study that we did using our emergency department, our IDNet network that we do in partnership with CDC. So we looked at patients who came into the emergency department at these 12 sites in our network all across the country, people with a UTI that was bad enough to put them in the hospital. So they're coming into the ED, but they're sick enough to get them into the hospital. We looked at what grew in them and how many of that ESBLs. We had 444 patients with Enterobacteriaceae, gram-negatives like E. coli, Klebsiella, and we found overall more than 20% of them had ESBLs. Now, most of them had risk factors. 86% of them had these risk factors, being in the hospital, sniff, et cetera, but 14% of them didn't. There was a big range between facilities. At some sites, it ranged from as low as 5%, at one site up to 45%. So it's worth knowing at your hospital what kind of your rates of ESBLs are, because it could impact our empiric treatment when these people show up in the emergency department. Now, if they were ESBL Mostly they were resistant to other things. Most of them, almost all were resistant to Cipro. More than 70% were resistant to trimethoprim sulfa, known as Bactrim. Most of them, however, were still susceptible to aminoglycosides like amikacin and to carbapenems like meropenem. So those are going to be our treatments. If you see this ESBL, somebody who has a known history, carbapenems are mostly going to be our go-to. They're the best studied. They are probably safer than aminoglycosides. Aminoglycosides, I think, probably scare docs more than they really need to, but they are very effective. So for carbapenems now at our hospital, because we see more than 20% of these ESBLs, and we're also seeing them in a fair number of people who don't have risk factors for them. So now if I have a patient who comes in with your UTI and sepsis, and by sepsis, I'm talking real sepsis here. I'm not talking about they've got fever and tachycardia. I'm talking about they have organ failure, their lactate's high. They're going to the ICU kind of sepsis. We're treating them empirically with carbapenems, not with ceftriaxone, which is what I routinely use for most community-acquired UTIs. So talk to your ID docs. If you're seeing a lot of ESBLs, you may want to change that strategy on your initial empiric treatment. Amikacin also works well. Now, zosyn, piperacillin-tazobactam. I know the ER docs, we likey that stuff for the nursing home patients and all of that. Now, you can get fooled here because your lab report, if they have an old isolate that you can try to base your treatment on, it may say it's susceptible to pip-tazo. Don't believe it. It's a lie because the in vitro susceptibility doesn't necessarily translate into success. And we don't recommend it even when it's said susceptible on the lab antibiogram. Your ID people are going to use something else. They're going to use either carbapenem or they're going to use amikacin. All right, so carbapenemases, these are basically beta-lactamase type enzymes, but they break down carbapenems. So that's the family of all the stuff that ends in penem, imipenem, meropenem, ertapenem, doripenem. Most often, it's again E. coli, Klebsiella. Some people abbreviate these as KPCs. You may hear the ID docs. That's a Klebsiella pneumoniae carbapenemase. Like the ESBLs, there's different classes. Doesn't matter for us, but it does matter for the ID people because for some of the drugs that were used for this, it may affect a little bit our choices. Now, because almost always these are also going to be resistant to fluoroquinolones, aminoglycosides, the other things that we often use for these, it doesn't leave us with a lot of options. So, for years we were using things like colistin, which is an old antibiotic left over from like the 1950s that we mostly weren't using because it has a lot of toxicities. Tigecycline's been out for a few years, but it has also a lot of negative side effects, nausea, vomiting in the majority of people who get it, or avacycline, another kind of uncommonly used tetracycline. There are some newer drugs for these super resistant gram-negatives, either these very highly resistant ESBLs or the carbapenemases. These are combinations of either anti-pseudomonal third-generation cephalosporins or carbapenems, like ceftolozane-tazobactam, ceftazidime-avibactam, meropenem, vaborbactam, imipenem, relebactam. Many of you have probably never even heard of these things because we are probably not going to be using these ourselves in the emergency department. If you're at the point where you're treating one of these superbugs or somebody has a history of it, you're going to be calling your ID doc. In fact, in most hospitals, you would need ID approval to use these drugs anyway. There is some nuance because depending on the different types of carbapenemases they have, then they may choose different ones. All right, so let's talk about Pseudomonas a little bit. Now, Pseudomonas can have these ESBLs and carbapenemases and all, but Pseudomonas, even if it doesn't have that, is a little bit different than some of the other gram-negatives. A lot of our third-generation cephalosporins, like ceftriaxone, things that we use commonly, are not active against Pseudomonas. So you have to use things like ceftazidime, cefepime. Pip-tazo, you can use against Pseudomonas, although it's not our preferred drug, actually, if somebody has Pseudomonas, because the other drugs, ceftazidime, cefepime, those things are actually more effective than zosyn for it. You can use aminoglycosides, in particular amikacin, astrienam, ciprofloxacin. There's a lot of resistance to that, and of course, carbapenems. But there is some resistance to all of these. So for people who have risk factors for severe Pseudomonas infections, like severe sepsis in a person from a sniff, they're neutropenic, a burn patient, or you may just have a high incidence of it. For empiric treatment, we'll often start with 2 drugs in different classes, which just makes it more likely that at least one of them is going to be active against it. We are seeing some more of these highly resistant, multi-drug-resistant Pseudomonas. Again, if you've got a patient with a history of these, you're probably going to be talking to your infectious disease specialist to get some advice on how that's going to work. So I'm going to finish off with a type of situation that we're seeing now more commonly in our ER. You probably are too. Urine culture positive for an ESBL producer. Patient was sent home from the emergency department. They're not sick enough to be in the hospital, but it's resistant to all the oral antibiotics. It's resistant to cephalosporin, Cipro. It's resistant to trimethoprim sulfa. And so how do you treat it without admitting them for ertapenem, amikacin, or one of those kind of things? Well, there are a couple of options that you can do. First of all, the first thing is take a step back. Maybe they don't need any treatment at all. The ones that I see, a lot of these are somebody who had an indwelling Foley. They got a culture for some reason, but they had no symptoms to suggest an infection. Maybe the answer is do nothing, because if they don't have UTI symptoms and they're just got a colonized Foley, they're going to grow this stuff all the time. So maybe you need nothing. If you want to treat it, if you're confident that it's only cystitis, you can often use nitrofurantoin. Many of them are susceptible. For pyelo, it's a little more challenging because the nitrofurantoin doesn't work. You can do multiple doses of fosfomycin, which is a drug that most will use single dose for cystitis. There are some case series showing that if you do a series of 3 doses, it's 3 grams PO, give it once in the emergency department, and then you give it 2 days later, and then a third dose 2 days after that. There's also some case series that's showing a 3rd generation cephalosporin, like oral cefdinir or cefpodoxime, giving it with amoxicillin clavulanate, giving it with augmented. That combination, there's some case series showing that many of these people you can treat successfully outpatient for pyelonephritis, even with these severe resistant ESBL genes. And remember, we don't want to be spreading these superbugs between patients. Wash your hands, because we are often the way that these superbugs get spread between patients. All right, thanks.